Please go
Okay.
ahead.
Okay, sir. Okay, so very good evening to the all the doctors listening from Uganda. So first of all, I would like to thank all of you for this invitation. And I know that my husband, Dr. Vivek, has been there before, and he had a good time there. And it is a pleasure and honor for me as a periodontist to share my views on this topic, management of gingival recession, and especially today because today is an International Women's Day. So I consider it more of a pleasure and honor to be, sharing on an international platform to young and enthusiastic dentists from Uganda. And the topic which was given to me was topic is the management of gingival recession, which is another favorite topic of mine. And I think as a periodontist, the maximum justice can be done to this topic because periodontology is one subject which deals with all the surrounding and the supporting structures, and pink aesthetics is what is coming into a lot of importance nowadays. So patients are conscious and they are aware of the basically the importance of the pink tissue. It is not like before where patients would have just dangling teeth, moving teeth, and lot of recession with a very unesthetic smile, and patients would really ignore it. So in fact, this is something where now it is in an era where patients do come to you with obvious complaints of unesthetic smiles, and they want some results. And it's not only for aesthetics, but it can be for some other reasons as well, like sensitivity. It can cause pain to the patient. It can cause basically it can be a source of root caries if not treated on time. And it is also a part of a comprehensive treatment plan or an interdisciplinary treatment plan, wherein a full mouth treatment is always considered to be complete only when the pink aesthetics are restored. So let's once again thank the Uganda Dental Association and all the doctors and the dentists who are listening today. It's a pleasure and honor again. So I start with this topic which is given to me, that is the management of gingival recession. So even though the topic says management of gingival recession, I would like to explain few facts about what is gingival recession. We all know that gingival recession by definition is apical shift of the margin of gingiva. So the margin of gingiva, when it starts shifting apically, there is loss of attachment and there is apical exposure and more exposure of the root surface. And eventually, from the margin, where it is generally 2 millimeters coronal to the CJ, it shifts up at the CJ and it starts going apical to the CJ. And as and more it progresses more and more apically, it is considered to be showing more loss of attachment. So, loss of attachment of 5 millimeters versus a pocket of 2 millimeters. A 5 millimeter is considered to be more, what do you mean? It is considered to be more of a serious problem because that means you have lost 5 millimeters of the attachment. 5 millimeters of loss of attachment and 2 of pocket on the root surface is a total of 7 millimeters of loss of attachment. So do not generally go just by the pocket depth, because that means that your pocket, even if it's 2 millimeters and you see half of the root exposed, it is a combination of 2 millimeters and 5 millimeters. That is a 7 millimeters you have lost already out of an average root length of 15 to 20 millimeters. So this is just a way of explaining to you that as you see the apical shift of the gingival margin, kindly note that there are many factors associated with it and we need to intercept it at the earliest. Otherwise, it's going to lead to more and more exposure of the root surface, and eventually you're going to have lost completely entirely the buccal surface. It leads to a dehiscence. Dehiscence is the complete loss of the buccal plate of bone, including that is a denudation of the root surface, and you end up with the completely bare root surface without any supporting bone. Sometimes it may be covered by the soft tissues, sometimes it may not be covered by the soft tissues. So if it is covered, it is sometimes a case of hidden or apparent recession where actually a lot of loss of attachment has happened, but because soft tissue is still covering it, there is a hidden recession. And actual recession is actually what I told you is the sum of what visible recession you can see plus the amount of hidden recession that is apical to the gingival margin existing on the root surface. So if you have gingival margin recessed by about 5 to 6 millimeters and you have a probing depth of approximately 2 millimeters, your total recession depth is 7 millimeters, which is more than what is actually seen. So always look for the true or the actual recession and not for the apparent or the hidden recession. These are just topics to start off with because you should get an idea of what we are getting into. So, as I said, gingival recession is a apical shift in the margin of the gingiva. It can be either trauma induced because of some iatrogenic habits, like people have some habits of taking some pins and putting it onto the gingival margin, or some toothpicks or wooden picks, or tailors will use those bob pins, or many things. It could just be trauma induced, or as simple as forceful brushing with a hard brush. Not proper brushing technique is used. At the same time, overzealous brushing more number of times than it is needed, and improper technique without change of brush frequently. It also is induced by bacteria. As we all know, periodontal disease is the primary cause of gingival recession. Starts with gingivitis, if not treated goes on to periodontitis, and then it leads to gingival recession. Again, as I said, it could be hidden, or it could be true, actual, or it could be apparent. So you need to calculate always the actual recession, which is actually going to give you the amount of destruction that has taken place. So bacteria-induced gingival recession is always pathologic, whereas trauma-induced can be iatrogenic. So both of them can be due to a centripetal mechanism or a centrifugal mechanism, wherein, uh, yes, sir, is there any problem, sir? Should I
Please,
continue?
members, yes, continue, Doc.
Okay, so as we said that it is mostly pathologic, and this is iatrogenic, and
Sorry.
it could be centripetal or centrifugal, wherein it is generally starting with the initiation of a cleft. We have all seen what clefts are. They are small triangular indentations on the margin of the gingiva, and these clefts are generally of two types. There is a red cleft and a white cleft. A red cleft is something which can be treated, it can be corrected. It is generally a interruption, or there is a break in the continuity of the soft tissue margin, and it is not a full thickness. It is just in the initial part of the marginal gingiva. It has not gone to the depth. It has not gone to the entire root surface. So it is something which can be corrected, and during your flap surgery or whatever periodontal treatment you're doing, a gingivectomy, gingivoplasty, this kind of a cleft can be eliminated. It can be incorporated in the incision, and you can take care of it. Whereas a wide cleft is something which is completely epithelialized. The root surface is evident at the bottom of the cleft. It is something which is epithelialized, and you really cannot treat it by doing, and it's a deeper cleft, so you cannot really include it in your incisions and all that. So wide cleft is something which is definitely going to lead to a future recession, and it is indicative of recession, and it also means that there is a epithelialized cleft there which you're not going to be able to treat unless you do some root coverage procedure. So this is basically the way you're supposed to start with the treatment, like understanding what kind of treatments are needed. What is the prevalence of gingival recession? Mostly you see it on buccal surfaces, as we all know. Generally, and treatment is also done on the buccal surfaces because we need to, it's more of aesthetic concerns. So palatal recession techniques are now coming in, root coverage techniques, but mostly we end up treating the buccal surfaces. With age, there is recession, malpositioning of the teeth, as we have seen, canines which are buccally placed or palatally placed, or any tooth which is prominent in the arch, which has a thin buccal plate, supporting bone, are more prone to recession. Already spoke about traumatic tooth brushing, forceful, overzealous brushing, wrong technique, wrong brush. Frequency of brushing, again, more number of times, irregular times, and unnecessarily, it can lead to this trauma-induced kind of a gingival recession. Poor oral hygiene is going to lead to gingival diseases, which are going to lead to periodontal disease, and then eventually loss of attachment. And gingival recession is also a sequela of periodontal flap surgery. Basically, before we go ahead with the classification systems, we have to understand that to communicate with each other as to what kind. Hello. They have been used to modify. So, hello, am I audible?
Yes, you are audible, Doc. Before you start, members, let's try to. Yes, you are audible, Doc. We can hear you. Members in the house, please let's mute our audios and videos so that we can listen to the professor well without interruptions. Thank you. Let's go on, Doc.
So we need to understand what is the Miller's class 1 and class 2, which is a commonly followed. If there are some periodontists on this platform right now, they would know that there is a common classification that we all follow and very easy to understand. The diagram is self-explanatory, where you can see that a class 1 recession is not extending up to the mucogingival junction. It is well defined and confined within the attached gingiva itself. It can be a shallow or it can be a wide recession, and narrow it can be a deep recession. Class 2 is extending up to the mucogingival junction or beyond it, but there is no bone loss or soft tissue loss interdentally. So these are better for complete root coverage. Root coverage techniques we are going to be discussing as we move ahead. They are obviously what the topic about is today, that we cover the recession and we end up treating the recession problems and management of gingival recession for better aesthetics as well as function. A class 3 gingival recession is where there is a loss of bone and soft tissue interdentally, and there is some amount of malpositioning also. All these recessions after class 1 are going to extend up to or beyond the mucogingival junction. A class 4 recession is again up to or beyond the mucogingival junction, but there is severe loss of bone and soft tissue interdentally with malpositioning of the teeth. So the class 3 and 4 are not ideal for gingival recession treatments. Basically, so they are not going to give you the kind of prognosis that we are looking for, because we want complete coverage most of the times. But because the bone and soft tissue have been lost interdentally, we are not going to get that recession coverage. This is a very broadly acceptable classification, and now there are many other classifications given as modifications for this Miller's classification. The Mahajan modification is very important, wherein they have seen the relationship with the interdental CEJ and the basically the buccal CEJ, where they could identify the cases where you could predict the prognosis of the root coverage procedure based on whether the margin was apical to the CJ or coronal to the CJ. So there are various classifications in today's times. We have the Nordland and Tana from the old, we have the Kumar and Masumati classification, you have the Pini Prato classification, and the latest is given in the 2017 classification, where they have given RT1, RT2, and RT3 as the classification system for maintaining the recession records. So these are various systems which we have been following from several years. One of the common classification systems also gives you whether the recession is a shallow or a wide recession. It can be a shallow narrow, shallow wide, deep narrow, or deep wide. Now, generally, a deeper recession and a narrow recession is better for coverage, followed by a deep wide, followed by a shallow narrow, and then a shallow wide. A shallow wide recession is not going to give you any better outcomes, because it's almost like the entire margin has moved apically. So you always need something which is more narrow and slightly deeper compared to something which is wide and shallow. So gingival augmentation procedures can be apical to the area of recession, where you only want to increase the width of attached gingiva for better function, because the width of keratinized tissue is nowadays gaining a lot of importance, because it helps in maintaining the functions like mastication, speech, brushing, everything. And even when implants are concerned now, as periodontists are all, it's akin to implantology. So we have to almost, deal with every kind of situation around implants the way we deal around teeth. So the width of keratinized tissue or the attached tissue is gaining a lot of importance even for the health of implants. So any technique apical to the area is going to be gingival augmentation technique for increasing width of attached gingiva or keratinized mucosa when it comes to implants. Or anything which is coronal to the area of recession is going to be root coverage procedures, wherein you're only concentrating on gingival recession. You're not going to talk about anything apical to the area of recession. So our topic today is generally for gingival recession coverage. So we are going to speak upon the root coverage procedures, which is augmentation coronal to the area of recession. So I already spoke about visual recession and hidden recession. Now, hidden recession is not what we are looking for. What we should look for is a actual recession, which is a combination of the visual and the hidden. As I told you, always add up the combination, which is a visible part of the exposed part of the root surface plus the part which is hidden below the gingival margin. What are the predisposing factors for recession? We have already spoken about the prevalence, but what are the predisposing? Because unless you know the predisposing, you cannot correct them during your treatment procedures. First predisposing factor is inadequate width of attached gingiva, wherein there's going to be a constant pull on the margin of gingiva, and that pull is going to lead to recession because there's going to be there's tension. There's something called as a tension test, which is going to be positive, and that continuous tension is going to lead to deflection of the margin, plaque accumulation, and apical migration, most of the times associated with an aberrant or a high frenal attachment, muscle attachment, crossbite occlusion, or prominent position of the tooth in the arch leading to dehiscence, which I already spoke about. So malpositioning, buccal lingual positioning of the teeth, thinning of the bone, unsupported margins can again lead to basic problems like recession. Dehiscences are absence of cortical plate completely, exceeding to almost half or more of the root length. Fenestration is a small circumscribed window which is there. After you reflect the flap, you will see the fenestration, which is a small bony window. Those areas can be covered better than a dehiscence. Precipitating factor, predisposing factor is something which is anatomic, which is inherently present, and you do not have to, it's not something which is going to be induced by someone. It's an anatomic problem basically. But predisposing factor is something which is induced, like when a brushing is done vigorously, as I said, wrong toothbrush, hard brush, not using the proper technique, recurrent inflammation, laceration caused by traumatic injuries, iatrogenic factors, as I already spoke about. It can be thermal injuries also because of some chemical or caustic agents. Can be traumatic overbite, trauma from occlusion. It could be drug related. So all these causes are the precipitating factors which increase what has already been started. And what are the other what is the concern basically? What are the concerns that patients come to you with? Root sensitivity, cosmetic problems. When a patient smiles, they'll see more of the root surface. They'll say the tooth is appearing longer, so they need some treatment for that. Sensitivity obviously is going to be a part and parcel of it, because this happens even after flap surgery, when because of shrinkage of tissues, patients come back to you with sensitivity and they say that the tooth is looking a little longer. But then to eliminate granulation tissue, you have to sometimes bear with these consequences. But there are nowadays techniques during flap surgery wherein you could not completely degranulate and maintain the healthy granulation tissue to retain the bulk, so that the tissue does not shrink completely. Professional concerns, root caries. From the dentist point of view, you will fear that if you do not treat the recession, there will be root caries. Aesthetics of restorative dentistry may be in question even while placing crown margins, or to blend the pink and the soft tissue, the pink and the white component of aesthetics, you may have to do a root coverage procedure. As I said, it's a part of interdisciplinary dentistry now, and periodontics is the hub of interdisciplinary dentistry, where a lot of outcomes of other dental procedures depend on the health of the current status of the periodontium. So even though a tooth can be restored well, but there is no sound periodontium, or health of the gingival tissues is not there, it's going to create problems. Pulpal pathology also is a problem because it can lead to multiple types of problems. So coming to various techniques for root coverage, as I said, root coverage techniques are the ones coronal to the area of recession. So you're going to augment coronal so as to cover the exposed root surface. You have various types of grafts, like the connective tissue grafts, the free gingival grafts, the pedicle grafts. Then you have the advanced flaps, the laterally displaced flaps. So we'll be covering all these techniques with the cases in the forthcoming presentation. So root coverage procedures can be divided into pedicle soft tissue grafts. Pedicle, as we all know, as dentists, pedicle is something which has a base. So a pedicle graft is something which is taken from the site adjacent to the recession, and it is shifted from the site laterally. So it is either a rotational or it's an advanced flap, because it has a base. It is something which is not detached from one side and put on the area of recession. So these generally are rotational, laterally positioned, double papilla flaps, transpositional flaps, and you have advanced flaps in which you have the coronally position and the semilunar flaps. Then you have the free soft tissue grafts, which you harvest. A free graft versus a pedicle graft. A pedicle graft has a base, so it is generally shifted from the lateral side onto the site of the recession, or coronally advanced from apical to the area of recession to the area of recession. So these are something which are like flaps which have a base to it. A free soft tissue graft is something which is harvested from a donor area, generally the posterior palate. It becomes a free graft, and then it is sutured onto the recipient side, is the site where you have the recession and you want to do the root coverage procedure. So in that you have the free gingival graft, the free connective tissue graft, and you have the subepithelial connective tissue graft with variant techniques. Additive treatments are also there now, where you do the root surface biomodifications to make the root surface more amenable, or what you say, more conducive to accepting the root coverage technique, so that the graft or the pedicle flap or whatever you're going to harvest and you put it in that area of the recession is going to be accepted better. You have an enamel matrix derivatives like endogain, which are they are amylogenins, basically taken from the advanced wealth stage of root development. So they mimic what happens during root development, and they induce growth factors and convert the undifferentiated cells to the progenitor cells to the cells which we actually want. That is the gingival fibroblasts and whatever other regenerative cells, and they come and lay down the new tissues. They help in lay down new tissues. So it's basically a regenerative procedure. And GTR is a guided tissue regeneration procedure with the use of membranes, which again helps in maintaining the position and the space and clot stabilization and helps in establishment of root coverage. Nowadays, you also have techniques of tissue engineering. Tissue engineering is recent techniques wherein these are all lab grown, which are in the outer lab environment, and then they are put back into the oral cavity. So these are generally based on the principles of cells, signaling molecules, and scaffolds with constructs. So these are all prepared under laboratory conditions, and then they are going to be, of course, the source is from the human origin. The cells are extracted like stem cells, and then the tissue engineered constructs are prepared in the lab, and then they are placed back in the patient's mouth. So you have passive engineering where you have GTR therapies, barrier membranes, you have biologic based cellular dermal matrix, which is matrix which is derived from humans, basically, like how you have bone grafts, which are like the DFDBA bone grafts from human banks. Similarly, the cellular dermal matrix is what is taken from humans, and it is the antigenic process, antigenicity is taken out, and it is just cross-linked collagen, basically, and that helps to reconstruct in the areas, and it prevents the use of second surgical site like from the palate, which we'll be seeing in the coming slides, where most of our graft procedures are harvested from the palate. You have active engineering, as I said, tissue engineering, where you have enamel derivatives, you have growth factors, and you also have cell therapy, where autologous fibroblasts are harvested from the humans and from this like a stem cells, and then they are formed as reconstructs, cell sheet engineering in the labs, and then these bilayered cell therapy or the isolagen constructs are then placed back into the site, especially for recession coverage, and that helps in avoiding a donor site from the palate. Now, free soft tissue graft procedures, most commonly used free soft tissue graft is the free gingival graft or the free mucosal autograft, which is taken from the posterior palate. It is a free mucosal, free because you're harvesting it without a pedicle. It is taken from one donor site and taken to the recipient site. And then it is basically an epithelialized graft because you're taking it with the epithelium, and it is a autograft because it is from the patient's own. So it is a patient's own, it's a gold standard. You're not using any external source, you're not using any human tissue bank, and it is the best for gaining the ideal outcomes. So it helps to increase the zone of attached gingiva. It also helps in root coverage. The initial technique was given by John in 1963, wherein you first deepithelize the area of recession, you expose the connective tissue bed, prepare a recipient site like this so that the connective tissue to connective tissue will bind. You never bind epithelium to connective tissue. So a recipient site has to be prepared. And following that, you harvest the graft from the palate and then you suture it onto the recipient site. So if you see this area of recession is there. It's a class 1 recession. I've already explained what Miller's class 1 to 4 stand for. So this is a simple class 1 recession, but it's a shallow recession. It's a wide recession, so it's not the best. It also has less attached gingiva. So you can see that the recipient site has been prepared by deepithelizing here. And then you have harvested this graft from the posterior palate. The ideal zone for harvesting a graft is from the distal of the rugae till the mesial line angle of the first molar, because the greater palatine vessel runs along the entire course. So you have to be very careful not to injure it or damage it during this procedure. So this is a very important step that you have to keep in mind, the anatomical landmarks. Do not go too posteriorly. In fact, if you go little anteriorly, it's safer, but then you are on the rugae. So you have to take care what kind of area you're going to graft it on. Like, what is going to be the recipient side? Because you, whatever area you've taken it from, the connective tissue on that part has the genetic determinant of what kind of epithelium is going to form on top. So if you have taken it from an area where there is rugae, you may get something like a rugae-like area, which we do not want. As it is, it's a graft, it's a transpositional onlay graft, which you're going to take from one side and put it on the other. So there are chances that it ends with a little bit of a tire patch appearance, which is a common factor associated with free gingival graft healing. But it can be corrected in the second and the third stage of healing by doing a little bit of plasty. So this is how a graft is harvested from the posterior palate, and then it is sutured onto the recipient site. You can see this, and you can see that there is an increased zone of attached gingiva. This is primarily one of the best techniques for increasing the zone of attached gingiva, and followed by secondary root coverage, which you will get as a part of creeping attachment. It can also primarily help to cover the root, but you have to be sure that the attached gingiva also is increased along with that. Otherwise, if the attached gingiva is not increased, then again there's going to be the same problem, that constant pull on the margin, and that's going to lead to gingival recession. So you can see the outcome in the previous case. There is an increased zone of attached gingiva as well as recession coverage. So it's achieved what we were looking for. So second case, you can see this is a Miller's class 2 recession, which is going till the mucogingival junction. It is not having much of a loss of bone and soft tissue. It's just a malpositioned tooth. So it is good conducive for root coverage. However, you have to be careful of what caused this malpositioning, whether it was due to a trauma from occlusion or it was originally like that, because patient said it increased over a period of time. Anyway, this was primarily taken up for increasing width of attached gingiva. However, the results of this were very promising in terms of root coverage also. Same thing from distal of canine to the 6 midline, you have taken the free gingival graft from the palate. This is how an ideal graft looks. It's an epithelialized graft, epithelium and half a layer of connective tissue. You're leaving behind connective tissue and periodontium intact. So this is the kind of graft that we are going to harvest, ideal graft, which is sutured. You can see that it's slightly sutured at the apical part because the primary aim here was to increase the width of attached gingiva and not initial root coverage at same point of time. So this is the recession, or this is the area apical to the gingival recession. So initial stage of definitely got a good zone of attached gingiva now. The patient can start brushing. His primary complaint was he could not brush, so it was leading to gingival recession. So there is an increased zone of attached gingiva here. This, over a period of 18 months, has creeped up. The free gingival graft has a property of creeping attachment because of the properties of the gingival fibroblast remodeling. So it starts creeping in a coronal direction like this, and you can see that over a period of 18 months to 2 years, you can see that the graft, which was initially only for the attached gingiva, has covered up almost entirely the recession. What remains is a little wider and a shallower part of the recession, which looks difficult because of the prominence and the position of tooth in the arch. However, this much was a like a gift for the patient, because patient was initially concerned of losing the tooth. So definitely that's not going to happen. At the same time, he's got a wide zone of attached gingiva, keratinized tissue for placing the brush. Brushing is much more easy. The movements of the lip are now better without any pull on the margin, and this is stable tissue forever now. So this is only going to creep higher. If required, you can do a second procedure wherein you can harvest a connective tissue graft again and place it as a small pouch procedure just to increase this, or you could just do a second stage where you could coronally advance this tissues. Or you could do a gingival unit transfer. So this is how the free gingival graft works. And as I said, creeping attachment can be almost up to 3.5 millimeters in 2 years. So we've seen something like this happening in this case, and that was very encouraging for both the periodontist as well as the patient. This is a case where you can see that there is trauma from occlusion. Basically, the bite is a deep bite, and this patient has continuous plaque accumulation because of, again, you can see this pull on the margin. There is inadequate width of attached gingiva here. So this is causing this tension on the gingival margin. Patient cannot brush here. There's continuous inflammation local factors which were removed that led to bleeding. So again, a graft was planned here with a free gingival graft technique itself, and deepithelialization, increase in the vestibular depth, ideal graft harvested from the palate. And you always need to trim the undersurface of the free gingival graft because it contains many times adipose tissue, because you're taking it from the posterior palate. So we don't want that adipose tissue to interfere with the healing of the graft, because you want connective tissue to join to connective tissue. That union has to be, it's like a glue basically. So we want to make sure that it is only connective tissue and not adipose tissue. Most of the times after harvesting, you can give a Holly's retainer with a pack or a Abgil just to stabilize that, because it bleeds. So you have to control the bleeding with continuous pressure of 15 minutes, followed by the like a Holly's retainer, which I already spoke about, which puts pressure. So this is the initial stage of healing of the graft. A graft which is taken up will start looking pink after first 4 to 5 days. First 3 days it looks a little transparent and grayish because there are no blood vessels. It's empty. You have taken it from the palate. It's devoid of any blood supply, and then you are transfer it. You're putting it on the recipient side. So initial 3 days, the graft only survives from the blood supply of the recipient side. Okay, it's called as plasmatic, the serum basically. It gets nourishment only from the recipient side and it survives only on that. So it's called as plasmatic circulation. And then slowly the new blood vessels start growing into it from the connective tissue bed, and then it starts basically getting back its color. So in the first few days, it looks transparent or grayish, and then it starts looking pink. A graft which is not taken up well will look necrosed, it looks white, and sometimes it just completely comes off. So this is a well taken graft. Over a period of time, it starts remodeling. And then as you can see now, this patient I have seen recently, I do not have the photo, but it's healed very well, it's merged well. So this is a tire patch appearance which I was talking about. It's a common side effect of free gingival graft, but then it can be corrected by doing a laser gingivoplasty, or with your blade you can just do a little shaving of the external surface and then bring it back to normal level. But it definitely has improved the situation to a great extent for the patient. If you can see from the initial situation where there was no attached gingiva, there was recession, continuous pull, and now the situation where there is a thick and wide zone of attached gingiva and recession coverage. So that's a great benefit from the patient's point of view. So you can see the epithelium, connective tissue, and the submucosa layers. The epithelium is always thin, followed by thick connective tissue and the adipose tissue and bone. So when you take a free gingival graft, you're taking the entire epithelium and half a layer of connective tissue. So approximately your graft thickness total would be around 1.5 to 2 millimeters. You're leaving behind connective tissue and periosteum on the bone. So this is how your free gingival graft could be. Failures of free gingival graft could be instability of the graft, inadequate removal of fat and glandular tissue, proper suturing was not done, then you did not get good blood supply because of a wide area to be covered. Adaptation was not good because your suturing has to be very important, and this is how these are the three important sutures that you need to give while doing a free gingival graft. A horizontal stretching suture, which opens the blood vessels of the graft, which are now empty actually. So you have to open them so that the underlying blood vessels can grow into it, and the blood supply can again, restart the nourishment of the graft. So this is a horizontal stretching suture. The graft has a property of stretching, it stretches. So you can utilize that property to, sort of adapt it well. Then you have the circumferential suture, which goes around the tooth, from the buccal side interdentally on the lingual and comes back. And then you have the interdental concavity suture also. So you have three sutures which are important, but I would also recommend suturing four corners of the graft first, stabilize four corners of the graft, and then you give these kind of the stretching and the horizontal stretching, the circumferential and the interdental concavity sutures for additional stabilization. As I said, the first few days the graft survives only on plasmatic circulation of the underlying recipient bed, then revascularization from the second to the 11th day, and then the tissue maturation starts by remodeling between the 11 and 42 days. So, and then the final healing should be checked at 1.5 months, followed by regular periodic recalls at every 6 months to see the creeping attachment if it is happening or not. So basically, they are the gold standards autogenous free gingival grafts. Nowadays, we have a lot of substitute, not a lot, few substitutes in the market, which I will be showing in the forthcoming slides. But autogenous is the gold standard always because it is patient's own. There is no risk of any cross contamination, infection, and it is basically it carries the genetic determinant. The only drawback is you have to enter a second surgical site like the palate, and that can cause problems like morbidity, or patients may refuse that procedure because of the fear of a second surgical site. But if explained to the patient properly and if you can deal with it properly, definitely they are the most promising outcomes. Next type of technique for root coverage is advanced flaps, which are the pedicle flaps. It can be coronally advanced flap or it can be lateral pedicle flaps. Now, this is single, again, simple case of Miller's class 1 recession, not extending up to or beyond mucogingival, shallow wide again, but it is a very shallow recession. So these two teeth, you can see, again, it is happening because of a constant frenal pull. That frenal pull was corrected by doing a laser frenectomy. This is a this is a semilunar advanced flap wherein you just do a semilunar partial thickness incision and you join it with the sulcular incision from the gingival sulcus, and you sort of undermine it till you can join both the incisions together, and that flap becomes mobile. So once the flap is mobile, then you just slide it coronally, you advance it coronally, and you hold it in place till the flap becomes stable. This may not require sutures because it's just the attachment of the underlying the connective tissue of the underlying surface of the flap to the the root portion of the tooth is itself enough at the stable clot, and then you can just put a periodontal dressing to stabilize this particular flap. And you can see that it helps, it really takes up well, and it is a very small what you say localized procedure without any comorbidity or no second surgical site. But that is only because this is a shallow recession and it is not going to require augmentation of attached gingiva, because the existing attached gingiva was more or less okay for this kind of a procedure. If attached gingiva is less, you cannot, and even if in today's times, a lot of importance is given to keratinized tissue width and gingival thickness. So you need to have GT and KTW. So GT is gingival thickness, which here you can see is good enough. Only then it can give you that kind of a coverage. Even if KTW is okay, but GT is less, you may not get this outcome because this thickness itself is what is going to help us in getting the root coverage. So coronally advanced flaps are the very important factor for achieving complete root coverage in terms of the position of the gingival margin. The After you advance it, where the gingival margin lies is going to give you a idea of the coronal advancement and what kind of results you're going to get. Coronally advanced flaps can be done along with now when gingival thickness is less or KTW is less, you need to augment. You are not only going to get results by coronally advanced flaps. So earlier case what I showed you was of a semilunar flap without any vertical incisions. A conventional coronally advanced flap has vertical incisions to it with a horizontal incision at the base of papilla. So these vertical incisions are beyond the mucogingival junction, because to advance a flap either coronally or laterally, you need to release it, and for releasing you need to go beyond the mucogingival junction. So you can see the flap is reflected beyond mucogingival junction. You can see the recession. This is the actual recession, which is the sum of the hidden and the visible recession. And once you see the root surface, you should root plane it thoroughly by using your Gracie curates. You can use a root biomodification using your citric acid, tetracycline. This is the older agents. Now you have EDTA, you have hyaluronic acid, you also have emdogain, and you have lasers now, the Erbimag laser, especially on the root surface, which will detoxify the root surface, expose collagen fibers, and help in better regenerative outcomes. Now, in this case, a PRF, that is a platelet-rich fibrin, which is your own blood derivatives, which we are using, the PRPs, the platelet concentrates basically. The platelet-rich fibrin has been used because this again helps to overcome the comorbidity of a second surgical site from the palate. At the same time, it has growth factors, it kickstarts the wound healing. Though there are conflicting reports about its efficacy in complete root coverage or regeneration, it still definitely is showing promising results in maintaining and increasing the soft tissue biotype there, thus helping in healing outcomes and stabilizing the flap. So you can see the PRF has been sutured, followed by coronally advancing the flap. You can see it is covered the recession, and you see this post-operatively, the results are very promising. Another technique being tried currently is the use of hyaluronic acid gel along with coronal advancement of the flap and use of platelet-rich fibrin. The same platelet-rich fibrin can be ideally replaced with the connective tissue graft, which I'll be showing later. Connective tissue is the gold standard for autogenous grafts, as I told you. It's like the free gingival graft was an epithelialized graft. A connective tissue graft is not an epithelialized graft. It's a subepithelial connective tissue graft, but that gives gold standards in terms of regeneration, in terms of root coverage, even color match, and ideal aesthetics. So this is a case where you can see a very nice flap reflected, the actual recession, and then little bit of hyaluronic acid is being on the root surface. Hyaluronic acid is ground substance, basically glycosaminoglycans. So it helps to make it is very conducive for attachment. It is very conducive for healing. It makes the tissues very plump, and it gives the what do you say? It is being used in every aspect now. It's skin and aesthetic procedures and cosmetology and everything. So it's basically helpful in healing, and it gives the plumpness to the tissues what is required. So here its ground substance is helping us to increase the volume of the tissues and promoting wound healing. So again, platelet-rich fibrin has been used, coronal advancement of the flap, and this is just in the initial stages of healing where you can see that excess tissue is formed. Now we need to reshape it or recontour it in order to get the in order to get the actual outcomes. This is a case of regenerative therapy where there's a grade 2 furcation involvement and recession. So you can see furcation involvement, you can see recession, exposure of the root surface. So radiographically also you can see this. The endodontic treatment has been carried out for this. A flap is reflected and grafting has been done for this furcation involvement to get bone regeneration there. And then the flap is again coronally advanced here and use microsurgical sutures to stabilize it, and you can see that how nicely this has covered the recession also. So it has also got a little bit of adequate keratinized tissue width and gingival thickness, and that is why these outcomes are possible. So always remember the importance of GT, that is the gingival thickness, in any root coverage procedure. So you can see these outcomes which are very promising, and it can be done very easily chairside. Coming to the connective tissue graft, as I said, it is a gold standard, and there are variant techniques of connective tissue for the donor side as well as the recipient side. So now you must have got an idea about how the recipient side looks and what the donor side looks. The donor is the palatal side, and the recipient side is generally the area of recession where you have de-epithelialized and exposed the connective tissue. So this is for a free gingival graft, but when you're doing a connective tissue graft, you don't actually prepare. It's not an onlay graft, it is always submerged. It is either, it's a bilaminar technique wherein a CT is covered with something always. So just have the pedicles, you'll have you'll have a papillae which are created, double papillae which are created by doing sharp dissection on either side, and the tissues are then laterally displaced. Or you'll have a flap which is reflected, and then you again cover it over that, like the way I showed you for the platelet-rich fibrin, or a lateral pedicle flap, or a pouch. So there are variant techniques for covering the roots with a connective tissue graft. And as I said, for root coverage, it is the subepithelial graft which is the gold standard. The graft which is the gold standard for apical to the area of recession, that is augmenting the width of attached gingiva, is the free gingival graft, which we have already discussed. So you can see the difference here. Here a flap is reflected, or it is known as a trap door, which is reflected part of epithelium and connective tissue on the palate, and then a full thickness connective tissue graft is harvested from the palate. So this is how the differences are between the connective tissue and the free gingival graft. In the preparation of the recipient side, you have various techniques like the tunnel technique. Tunnel technique is used for multiple gingival recession, wherein with your tunneling instruments, you prepare pouches by going under the gingival sulcus, and you increase the depth all around by using your tunneling instruments, and then you slide the connective tissue graft. So this is an example of tunneling. The way you can see this is multiple gingival recession. So you can do a tunneling technique, and you can slide the connective tissue graft in this manner, and then advance the flap slightly, and you can get the coverage. So donor sites, there are many modifications. As if time permits, I will come back to this and show it to you. We'll start with the cases of the connective tissue graft. The connective tissue graft, this is a case of class 1 gingival recession, shallow recession, wide recession, anterior zone. Many a times you get these kind of areas. So this is a pouch being prepared now. Nowadays we are using tunneling instruments, using micro surgical blades, which I already showed you in the PRF case. And basically you give a circular incision and you go on increasing the depth of the sulcus all around till you prepare a pouch. This is a single recession case wherein a pouch has been prepared, a connective tissue graft is harvested from the palate by using a trapdoor technique. You can see that this is only the graft, which is a connective tissue, it does not have any overlying epithelium. It is slid into the pouch and then you can just give pressure sutures, initial healing, and you can see the graft which is well taken up and it has covered the recession properly. So this is a, and it has got a very good color match. In connective tissue, the blood vessels are retained because of the blood supply of the overlying tissues, and it's only the connective tissue, you're not carrying the overlying epithelium with it, and it is subepithelial. Now there are two reasons why it is called as subepithelial. One is that when you harvest it from the palate, you take a trapdoor, you reflect a flap, partial thickness flap, and then you harvest the entire connective tissue. That is why it's one reason it's called as subepithelial. Other reason is when you are putting it on the donor side, are suturing it on the donor side, it is always slid underneath a pouch or a flap, and that is why it's always subepithelial. There is something called as a free connective tissue graft also, wherein the graft that you harvest, a connective tissue graft that you harvest, devoid of epithelium, is placed on lay like a free gingival graft on an area of connective tissue to increase the width of keratinized tissue. So there are variant techniques. This is another case, Miller's class 1 recession. This is a case where you have done a coronally advanced flap without giving vertical incisions, but you have given them at the base of the flap and you just go tunneling and increasing the depth all around without actually giving any vertical releasing incisions. This graft is obtained from the posterior palate and then it is slid inside the recipient bed and multiple pressure sutures are given, and you can see that this is healing. Initially the graft heals with a lot of bulk and then it remodels and completely settles at a very clean marginal position. This is another case where you're giving a clavicular incision and a partial thickness flap. Then this is a graft which is harvested from the posterior palate. It is sutured onto that side. You can see how bulky it is looking right now. This bulk of the graft is making it look very unaesthetic actually, but over a period of time it will remodel and it almost shrinks 3 times its size. Graft is known to shrink 3 times its size, and you can see this picture wherein this graft is remodeled over a great period of time, and this bulk has almost disappeared. So there are cases where it happens in such a way that initially it looks very bulky and it doesn't look aesthetic, but once you give it time, time is the best healer. Mother Nature is the best healer, and grafts remodel. They have a capacity to almost so that's why when you harvest a graft, it is said that you should harvest 3 times the size of the recession. If a recession is 3 millimeters, it's always better to take a graft of almost 9 millimeters or 10 millimeters by 10 millimeters, so as laterally, apically, coronally, always it is going to cover the recession, and even after shrinkage is going to not again go back to its pre a stage where it was taken up before recession. So pre-operative phase basically. So that's why the bulk of the graft is important. Thickness of the graft is important. There are thick grafts and there are thin grafts. An average graft thickness is considered to be 1.5 millimeters for a recession which is of a normal size. But if you want to cover a wider area, a 2 millimeters or more thickness of graft is considered to be ideal. So always consider the local factors, the anatomy, look at all factors before you harvest the graft, because that's what is going to decide the outcomes. This is another case of tunneling technique. Tunneling technique, you can see that there are multiple areas of recession here. So we have prepared a pouch on individual teeth and then a tunnel was prepared. This graft is harvested from the posterior palate by a trapdoor single incision technique, and then it is placed inside that a big graft, so it was a little difficult. Multiple pressure sutures, you have to give pressure sutures to adapt the graft to eliminate any dead space and to stabilize the blood clot. And then you see the healing. As I said again, it looks very bulky, unesthetic initially. Patient also sometimes gets scared, but you have to explain that this is a phase of healing. It will remodel over a period of time, and you can see how nicely from the 15 days to 1 month to 3 months, 6 months. And these results are well maintained now because you have a wide zone of attached gingiva, you have a wide zone of keratinized tissue, you have good gingival thickness. So these results are stable. But always, as I said, initially when you're taking up the case, always evaluate the existing keratinized tissue width and the gingival thickness, and that's what's going to determine your outcomes. So ideal color match in connective tissue graft, 100% root coverage if your case selection was proper and your treatment protocols were properly followed out. As I mentioned to you, gold standard for aesthetic in terms of color match and complete root coverage outcomes. This is just a video which will show you how the graft can be harvested. This is just a pouch preparation. I'll go through it a little faster. Basically, I wanted to show the harvesting of the connective tissue graft here. This is how a partial thickness trapdoor is raised on the posterior palate with the epithelium and a thin layer of connective tissue. Do not take more thickness of the trapdoor because you'll end up losing the thickness of connective tissue graft that you actually want. This is also the technique for somewhat the technique for your free gingival graft. If you give the fourth incision at the base, it will become a free mucosal autograft. So here you're keeping the trapdoor intact and then you give four full thickness incisions and release the connective tissue graft from the palate. You trim all the adipose tissue as I already told you because that interferes with the healing. And nowadays the technique is preferred by the most of uh, the skilled clinicians is to take a epithelialized graft from the palate and then slightly deepithelize it externally with the help of your very fine scissors or your blades, and then use it because a graft which is epithelialized, uh, easier to harvest, plus you're not wasting more of the graft in your deepithelization, in your trapdoor. So you can just take out a very thin layer of epithelium. Also, there is less chance of adipose tissue coming in with a epithelialized graft because you're not going that much deeper to get the connective tissue. So there are some benefits like this, and eventually you suture the recipient as well as the donor side. So this case was basically taken up to increase the biotype of the tissues there. So this is some kind of a decision-making tree when you want to decide. As I told you, two important factors you have to check is bone level, the loss of bone and soft tissue incidentally, the position of CEJ, the keratinized tissue width, gingival thickness, and you also have to see what is the position of the tooth in the arch. Coming to the more new techniques, we'll briefly go through this. You have the pinhole technique, which has been designed recently just with the we do not now everything is getting more conservative, minimally invasive. We want to avoid vertical incisions because they cause a little bit of delayed healing, plus there's a blood supply is affected. So we this kind of techniques for preparing the donor side, the recipient side, just with a pinhole, you have variety of instruments through which you can go on releasing the tissues in order to make them free, and then they can be advanced coronally. This was given by Chow, and it is a scalpel free, suture free procedure. A suture may be required eventually to advance the flaps and stabilize them, but there is no blade required. Only with these instruments, the tissues are undermined and they are released to advance coronally. So, this is a pinhole technique, and this has shown promising results too. Specially designed elevators are there for that, which help to release the tissues. The Vista technique is given by Zade in the year 2011. I had the privilege to watch and meet Dr. Zade in one of our conferences recently. So it's a vestibular incision subperiosteal tunnel axis where you're avoiding any vertical incisions, you're avoiding any kind of major releasing incisions, just through one incision which is given in the region of vestibule, a vertical incision about 10 to 15 millimeters. Through that, the tunneling instruments, which are specially designed for Vista, are introduced and the tissues are separated, and these tissues which are separated are then coronally advanced, and then you augment that area either with a connective tissue graft or a collagen membrane. So these are just some articles on the same where they have used combination of collagen membrane, connective tissue graft. PRF is what we are trying now because that overcomes the morbidity. And also there are now new variants in the technique wherein the incision is placed at the side of the frenum, So along with a V-shaped incision, like how you do your frenectomy, so you can achieve both a frenectomy at the same time a vestibular incision, and through which you can release the tissues. So this is a set of the Vista elevators basically, and these instruments will help to release different zones of the tissues. So as I said, a 10 to 15 millimeter incision is given in the vestibule. You can see this. So this is the area which had to be covered. So this incision was placed here far away. There is no circular incision given. The entire releasing has been done of the zones. There are three zones. Zone A is near the mucogingival junction. First you separate this. Then with the other Vista instrument, you go to zone B, which is your attached gingiva, and with the third, you separate your papillae and the sulcus. So this whole unit becomes freely mobile, and you can see this. This is now coronally advanced, and then either your platelet-rich fibrin or your connective tissue or collagen membrane or any substitute is introduced through this and sutured, and you can see the outcome. It is very promising. This is only because here your keratinized tissue width, the thickness GT and the keratinized tissue width before starting was more or less promising, and then the incision was placed here. This whole unit has been relieved and coronally advanced, and you get promising results. This is the way you can release the tissues. This is just to show you a brief idea about how the vestibular incision is given, and with the various Vista instruments, you go on releasing it. So this is the zone A which is being released first. That is the zone beyond mucogingival junction. Once that is released, then you will come to the zone B, that is your attached gingiva. So it is laterally as well as coronally the tissues have to be released. What are the various factors which will determine the outcome? Donor site, use of adjacent area, amount and thickness of keratinized tissue, thickness of bone, size of adjacent interdental papilla. Recipient site, either the number of teeth, degree and width and depth of the recession, amount of existing keratinized gingiva, relation with the adjacent interdental papilla, and alignment of teeth. These are the factors which are going to determine your outcomes. Variant techniques for connective tissue graft harvesting on the palate, single incision, I've already shown you. This is your Langer's technique with a double incision. Then you either give one single, one vertical, reflect the trapdoor, and then harvest the graft. Or you give, this is your conventional class C type A, where you give three partial thickness, reflect this flap like a trapdoor, and then harvest the graft. So these are the variant techniques. These are some of the substitutes which are available in the market where you don't want to do a second surgical site like the posterior palate, because patients are scared. Sometimes surgeons are themselves scared to touch the palate, because of the fear of the greater palatine. So in any which case, if you can avoid a second surgical site, is better from the patient's point of view. But as I said, they are the autogenous, so they are gold standards. They are inexpensive. They are the patient's own. But problem only is that the patients are scared. So to overcome that, you have various substitutes like the acellular dermal matrix, which is, as I told you, it's alloderm, which is a human-derived one. It's basically cross-linked collagen from which the antigenicity has been removed. But they are very expensive because a single 15 to 20 centimeters or 20 millimeters will cost you around 20,000 or so. So it depends on the affordability. This was a case which is tried, but then the patient, this is how the alloderm looks. It should be moistened with saline. It has a tissue side and it is epithelium side, which needs to be checked before actually using. You also have Fibro Guide and Mucograft currently, which are by Geislich, and they are though there is a mention of this, there does not have any, every company has a different kind of, tissue substitute. These are for palataless surgeries where you want to avoid any second surgical site on the posterior palate. So these are basically, they are xenograft like porcine, bovine, porous, resorbable, and volume stable collagen matrices, and they help in doing the same job as what a free gingival graft or a connective tissue graft would do. And they are promising, but as I spoke, they are expensive and they are not of the human origin. So we have to be clear while talking to the patients about that. Microsurgery, just talking briefly about it, refinement in the surgical technique as we are going from conventional to the latest, by which normal vision is enhanced through magnification. So there is use of very fine instruments, ophthalmic blades, very fine sutures, 60 and 80 sutures, and with the use of magnifying loops or surgical operating microscope. So a single case recession, Miller's class 1, This you can see the ophthalmic blade, very fine, sharp dissection of flap has been reflected. Recipient connective tissue bed is created, and now graft is being harvested with the trapdoor technique, the class 3 type A, with 3 incisions on the posterior palate. You reflect the flap and you give a full thickness incision in which you harvest the graft. Connective tissue graft is sutured. You can see the microsurgical sutures. They are very fine sutures and they are stabilizing the graft well. This is the green light or the green filter of the surgical microscope, which can actually show you the at the blood vessel level. And this is all done at 16 times magnification on a surgical operating microscope. You can see beautifully the graft of uniform thickness being harvested and then sutured in recipient side, good healing, and then the graft has been taken up well. This is a microsurgery for a free gingival graft. The more precise instruments you use, the more magnified vision you have. You want to do more precise, painless, and minimally invasive surgery. So you see the graft margins outlined because you've seen under magnification and harvested this. Though literature does not really recommend harvesting a graft under microscope because it's difficult to turn microscope, but now you have tiltable binoculars and you have Mora interfaces by which you can really turn the microscope anyhow. So you can even view the posterior palate. So full thickness, this is a free gingival graft, epithelialized graft, harvested, and it is sutured using the microsurgical sutures, and you can see the very nice rapid healing. One of the properties of microsurgery is faster anastomosis of blood vessels and very rapid wound healing, better color match. So you can see all these outcomes happening here. So this is such a deep recession, class 2 recession, and after the graft you can see very nicely the healing has happened, a very wide zone of attached gingiva, creeping attachment, as well as almost 75 to 80% of recession coverage, and whatever remains is because of anatomic, that is a predisposing factors like the position of the tooth in the arch, malpositioning and prominence. This is another case of pedicle flap, which is a lateral pedicle. Sorry, we are coming now to the lateral pedicle flaps. So the what we spoke earlier was the coronally advanced. Now this is the laterally advanced flaps. So you can see that it has been taken from the adjacent recipient donor side, not from the palate. And you're shifting this zone of gingiva, which is on the adjacent tooth, to the area of recession. So this is the area of recession. You de-epithelize this area of, once you prepare this with an external bevel incision, you will reflect the flap from here. You can see that this flap has been reflected and it has been now slid laterally to cover the area of recession and suture. So this is a lateral pedicle flap, but for that you have to be careful that this tooth does not have recession and you do not end up with a dehiscence here. So based on that, you have to check whether you will take a partial thickness flap or a full thickness flap. So this is how the healing happens. This was pre-op, this is after the flap, and this is during the healing phases. So these are procedures which can be taken up easily, and provided the area has attached gingiva and keratinized tissue with gingival thickness. So as I said, they are the prerequisites for any recession coverage, and all the more for advanced or pedicle flaps, because if there is no attached gingiva laterally, you will not be able to move it coronally or apically. Coronally or laterally, sorry. Then one more technique that we can use is a two-step technique where you have done the free gingival graft, increase the width of attached gingiva, and now you're going to coronally advance that after gaining the attached gingiva. Then you can either do a connective tissue adjunctively or you can just shift the whole unit coronally and then lead to recession coverage. So these are some variations of the pedicle flaps. A pedicle flap, you can have either, as I said, partial thickness. It can be a full thickness with the bone being exposed. There should not be tension on the pedicle flap, otherwise it will fail. And when will there be a tension? If this zone of attached tissue or keratinized gingiva was inadequate. So make sure that there's no tension. If there is, give a cut back incision so that it moves easily onto the other side, and then it has to be stabilized well in order to get the good results. So this is the reasons for failure. Coming to the active and passive tissue engineering, just briefly going through them. Already spoke about enamel matrix derivatives. They are amelogenins. They are the basically the root sheath proteins which are taken from the advanced belt stage. So it's something from the porcine origin again. The powder liquid form which has to be mixed into a syringe and applied onto the root surface. It helps in undifferentiated mesenchymal cells to be converted to differentiated mesenchymal cells, like the pre-fibroblast or the pre-osteoblast will convert into fibroblast, osteoblast, cementoblast, and they will lay down the new tissues. So basically, it's a regenerative procedure and it's a regenerative matrix. And however, it is the FDA approved and it is the only form of derivative which has shown regeneration even periodontally. But again, the availability and the concerns for using it are hardly any. It's you have to explain to the patient and it should be available at your disposal. So coronally advanced flap is always better if you use it with some adjunct, and enamel matrix derivatives have also shown promising results. So this is how you would apply it on the root surface and then advance the flap coronally. I've already shown you case of platelet-rich fibrin and connective tissue for the same. Then you also have recombinant human platelet-derived growth factor, beta tricalcium phosphate, and collagen dressing. So these are growth factors, and beta tricalcium phosphate is a bone graft and collagen is a dressing. So this is put on the root surface. The graft is beta tricalcium phosphate is a graft mixed with the platelet derived growth factor covered with the collagen, and then the flap is coronally advanced. So this is another kind of a tissue engineering technique. Then you have bilayered cell therapy where, as I told you, the fibroblasts are isolated and then they are grown in culture in the lab, and then you create this kind of a sheet which is can be used as a substitute instead of using a palatal graft. So this is a form of cell sheet engineering which is coming to use nowadays. And you also have scaffolds like fibroblast biodegradable scaffold, which are cultured gingival dermal substitutes, and they help in recession coverage. For this kind of things, you need to work with a lab or a research project or something wherein you can grow your constructs and then it can be used. So these things are under research because they are definitely going to help us overcome the morbidity of a second surgical procedure. So this is a Cochrane review of the various treatments that can be used, and uh, the subepithelial connective tissue graft has always shown maximum benefit and it is shown to be a gold standard in most of the root coverage procedures. This is how the PRFs are also being used. Finally, to evaluate your work, you have some indices. You have the pink aesthetic score, and you also have the root coverage aesthetic score. So these have been given to understand the outcomes of your treatment, in which there are various levels which have to be evaluated, including the mesial distal papilla, the soft tissue level, the soft tissue shape, then the alveolar process, soft tissue color, texture, all these points are evaluated, and a maximum score of 10 can be given for this. So these are the points which need to be checked when you're evaluating the outcomes. And what you want to see basically is an ideal color match. You want to see pink color, the aesthetics, you want to see stable gingival margin, you want to see the ideal papillae, you want to see stippling back onto the tissues. You do not want any scar formation. You do not want malalignment. You want the tissues to be in sync with the pink and the white component basically. And what you check nowadays is your average recession coverage and the mean recession coverage, that is the MRC, and the complete root coverage, which is your CRC. So CRC is what you are actually looking for, and MRC is something which you will generally end up with, especially when you're doing research studies, because that's what you look for eventually when it's a combination of several techniques. So coming to the end of this procedure, 86% of the times connective tissue graft have shown from the mean initial recession, they have shown root coverage. So they are considered to be the gold standards of root coverage procedures at all points of time. And as we conclude, we have to understand that the genetic determinant lies in the connective tissue of the donor site of the graft. So even if you're harvesting a free gingival graft or a free connective tissue graft, that carries the connective tissue part of that graft carries the genetic determinant. So that when you're taking a graft from epithelized area and you're putting it in a or a keratinized epithelium and then keratinized tissue, and then you're basically you're shifting it putting in a recipient area which is non-keratinized, like you have in the apical part of the gingival recessions, especially in the mandibular and incisor region where there is alveolar mucosa beyond your keratinized mucosa, which is non-keratinized. So still, how come the keratinized epithelium is forming? That is because when you're taking a graft, harvesting a graft from the posterior palate, that is entirely keratinized. There is no non-keratinized area on the posterior palate, palatal part, especially the posterior part. It's entirely the palate actually. It is continuous with your gingiva. So there is no non-keratinized. So it's entirely you're taking a keratinized part. So the genetic determinant of that part is going to carry the message that the overlying epithelium which is going to form is also going to be keratinized. So that is the basis of grafting procedures when you're taking free grafts from the palate, or it could be any other site like a edentulous site. It can be from the tuberosity area. Tuberosity graft is commonly being harvested in today's times because it has some benefits to it, but and less morbidity in terms of your greater palatine vessels and all that. But you have to be more trained and skilled in harvesting those grafts. So you have to understand this basic, and the entire outcome of all these grafting procedures lies on these five factors, that is adequate blood supply, stability, absence of infection, no occlusal trauma, and ideal, first and foremost, and the most important thing is ideal case selection. That comes first, because if your case selection is correct and you follow other things, you're going to get outcomes. But if you start with the case which was wrong and you do the best protocols, you're still not going to get outcomes because your case selection probably didn't have the right amount of bone, soft tissue, keratinized tissue width, or gingival thickness before starting, or if there's presence of infection which you have not treated, if your graft was not stabilized well with the ideal sutures, or blood supply was lacking, all these things are going to fail. So all in all, it's a combined approach. So know the anatomy well, know the techniques well, know the indications, contraindications of each, and then identify which technique to be used for which recession type and which particular area. And based on that, you will choose the donor side technique as well as the recipient side technique. So all these are the key determinants of successful outcomes of the graft, as grafting procedures form the mainstay in root coverage techniques. So thank you very much, and that ends my presentation for today. And I hope we have been able to showcase a variety of cases and the techniques for which are currently available for covering recession. So thank you very much.
Yes, thank you very much, Dr. Rashmi, for such a wonderful presentation. Members with questions, yeah, you can type in the chat or you can raise up your hand. Time will be given.
Am I audible?
Yes, we can hear you, Doctor. We give members some time for questions. Those who have questions, you can ask. Okay, Doctor, can you please comment on grafting people living with diabetes?
Sorry?
Can you comment on grafting in people with diabetes?
So I cannot understand. Grafting?
Yeah, like people with diabetes mellitus. So are there some consideration we should do?
For what is this? I'm not understanding. Sorry. What technique are
I'm
you asking?
saying,
Can I
okay,
just
like
comment?
grafting.
We are asking if the patient has diabetes mellitus, diabetic. If the patient is diabetic, what are the considerations you would take in?
What are the precautions?
Yes, and
Yes.
considerations you would do for the surgery.
Technique wise, you're not going to change anything in the technique, because see, a diabetes is a state. It's a medical state or a condition. So that keeps changing, right? It can be it can go to a increased impact glucose tolerance. It can become very uncontrolled. It can be a controlled, moderately controlled. So you have to identify what stage of diabetes it is. Whatever precautions are there for diabetic patients for any form of surgery, you have to follow it for this, because as I said, any form of infection which is present will interfere with your healing and outcomes of grafting. There can be delayed wound healing either at the donor and recipient side if the patient is moderately well controlled or poorly controlled. In well controlled diabetics, you can do all procedures because they're almost as good as a healthy patient. But in a moderately controlled or a poorly controlled diabetic, you have to educate the patient first. Of course, poorly controlled, you would not do surgery because they are contraindicated for surgery. In a moderate controlled patient where there are minor fluctuations, you can carry out this, but you have to do it under antibiotic prophylaxis, you have to make sure that the patient is under antibiotics throughout and post-operatively. The patient's blood sugar is under control and the patient takes care of the oral hygiene. Your stabilization of the graft has to be very proper. Your sepsis has to be very proper, and mainly the blood supply, which could be affected because of the diabetic status, has to be monitored, because the blood supply is going to actually determine the outcome of the graft. So as far as technique is concerned, there's no change in the technique. The technique remains the same. It's only the surgical precautions that you would take for any type of surgery when you're going to carry it out in the diabetic. But you would, of course, be more careful here because you're going to have a palatal site which is going to be exposed. So you make sure that the control of the diabetes is good at the time of surgery and you're doing it under antibiotic prophylaxis.
All right. Thank you very much. There's some other question.
Yes.
You talked about, yes, Dr. Abdu is asking, you talked about drugs that predispose to gingival recession. Can you give an example?
I talked
drugs
about
drugs that predispose to gingival recession.
Okay. See, there is no such drug. So there's no such drug like that. It is just that in drug-induced gingival periodontitis, drug-induced gingival enlargement, where because of some anti-hypertensive drugs, or it could be because of like amlodipine, nifedipine, or it could be immunosuppressants like cyclosporin, or it could be because of some other like there are 2-3 classes of drugs which are like phenytoin, anti-epileptic drugs. So these are commonly associated with gingival enlargement. So because of gingival enlargements, there is a lot of inflammation and clefts and all start forming. So that eventually leads to, gingival recession, loss of attachment and gingival recession. So there is no such one drug which will cause it. But yes, if a patient has any habit of using any caustic chemical agents like phenols or any such thing, or any acids which, patient has some habit, or iatrogenically any caustic agent has been used on the roots on the gingiva, then definitely that will lead to a destruction and loss of attachment and gingival recession. And thirdly, patients who are tobacco users, who have a habit of keeping tobacco in the vestibule, the tobacco quid in the vestibule, definitely have isolated deep gingival recession defects. And in smokers also there is a greater tendency, but more in tobacco chewers.
Okay, thank you very much for the clarification. And there's still some other question. Can you please give more light?
I can answer, yes.
Yes, there's another question in the chat. Can you please give more light on root coverage aesthetic technique?
Root coverage?
Aesthetic score.
Root coverage aesthetic score.
Yes, you give more light on it.
Okay. See, the root coverage aesthetic score is basically helping you to understand your outcomes of the root coverage treatment. So there are points which are going to evaluate in that. One is, I can go back to the slide for you. Okay, so you need to check the level of the mesial papilla. You need to check, that is 1. Then the level of the distal papilla, that is 2. Then the soft tissue margin, basically. By level, they mean the margin, the gingival margin. That's what you're trying to stabilize eventually. When you do a root coverage procedure, you're trying to stabilize the gingival margin here, right? So this is going to be the 3rd. Soft tissue shape is the 4th. Now, when you have done a root coverage procedure, you do not want irregular looking tissues. You do not want any aberrant or excessive tissue or proliferated tissue. You want tissue which is blended well. So you want this contour, your normal contour of the gingiva, which is scalloped. It is a thin scalloped, it can be thick scalloped, but it's an anterior region, it is going to be thin. Posteriorly, it can be thick. It cannot be overgrown or it cannot be exuberant. So that's what you mean by shape. 5 is alveolar process. Deficient alveolar process obviously means the underlying bony architecture that you would have determined earlier, because it depends on your biotype. If your biotype is a thin biotype, you will have a thinner bony housing. If your biotype is a thick biotype, you'll have a thick underlying bony housing. So you would have determined that generally prior to the procedure, right? So deficient alveolar process is generally obvious when you have done it, but sometimes you may be able to cover it with the thickness of the root coverage procedure that you have performed. Soft tissue color is, again, color match is very important because, as I told you, aesthetically, it's an important component of aesthetic dentistry. The pink aesthetic part is very important in today's time in interdisciplinary procedures. So you cannot do something and just not get the outcome of it. As I said, a free gingival graft would be contraindicated in the anterior aesthetic region, especially in the molars, because it will leave a tire patch appearance. So there you would definitely perform a connective tissue graft. And soft tissue texture, as I had mentioned, you need the stippling back. You need the original orange peel appearance back, because color, contour, consistency, surface texture, these are the main things that you would want, properties of the gingiva or healthy gingiva. So that you wanted seeing coming back after your root coverage procedures. So these are the points on which it has been given. So 0 points is failure of root coverage, in that the gingival margin is apical or equal to the baseline where you started with. So that means you have not got any root coverage, and that gives you 0 points. 3 points is for partial root coverage, and 6 points is for complete root coverage. So when you see that the margin is completely settled back, you're giving it 6 points. So call it complete root coverage. 3 points when it is partially covered, and 0 points when it is not covered. So if we are here now talking of an ideal situation where you have gained maximum of results. So you consider that you gained complete root coverage. So you got 6 points here. Then you have a 0 irregular gingival margin. Okay, the irregular gingival margin does not follow the CJ. 1 point when it follows the CJ, and you get the proper scallop back, because as I told you, your fine scallop, it can be a fine or a thick scallop, thin scallop or a thick scallop, but you have to get it back. So if you don't get it back, it is 0. If you get it back, you get 1. So you've got 6 plus 1 now. Then 0 points for scar formation and or keloid like appearance, and 1 point is for absence of scar or keloid formation. So 1 point you have got here because you do not have any keloid or scar formation. Sorry for this. Okay, so that's like 6 points here, 1 point here, 7, 1 point here, 8. Mucogingival junction, 0 points. Mucogingival junction not aligned with that of the adjacent teeth. 1 point when it is aligned with the adjacent teeth. So mucogingival junction is beyond your attached gingiva, and that's from where you are going to make the flap mobile. So that's 1 more point. So 6 plus 1, 7 plus 1, 8 plus 1, 9. And color. Color of tissue, if it varies from gingival color to adjacent teeth, it's 0. If it is matching, then it's 1. So a total of 10 points can be given. The maximum that you can get is 10, and the minimum that you could get is, 0, of course, where nothing has happened properly, and it could be a combination of 3, 4, 5, depending on what all parameters you have been able to match. So 0 points were assigned if the final position of gingival margin was equal or apical to the previous recession depth. That is failure of root coverage. Irrespective of color, the presence of a scar or a mucogingival junction not being at the right point, still that kind of thing was considered as failure. And 0 points are also assigned when a partial or total loss of interproximal papilla occurred following the treatment. So we do not want any black triangles forming after your treatment, okay, so which were not there before. So all these techniques, all these points put together will decide your total outcome, and you'll be able to understand what your score lies at. So I think this is about the root coverage aesthetic score. It was given by full author. Hello.
Hello. Thank you very much, Doctor. Thank you such. It's very clear. What I've explained is very clear. Thank you for this wonderful presentation. Members, any more questions? Maybe let me take this opportunity to thank everyone who has managed to attend the presentation. It's a little bit late in India. Right now it's almost 10. For us,
yes,
it's still early. So
yes, it's 10 o'clock here.
Yeah. So members, any more questions? I'm giving you like one person with a very burning question. We ask and we.
Yeah, no problem.
Professor Hegde, thank you very much for the presentation. I don't think any questions actually forthcoming, but it was a wonderful presentation and we really appreciated the time you have given us. Thank you very much.
Thank you for the invitation.
Thank you. Bye.
Yes, yeah, so could I have some snapshots of this, sir?
Sorry, doctor?
Have some screenshots been taken of this?
We have tried to record the presentation.
No, as in when I was presenting and the entire summary, has any screenshot been taken? A screenshot, sir.
A screenshot of what, though?
Of this Zoom meeting, sir. Or has it been recorded?
Dr. Rashmi?
Yes, have you recorded this meeting, sir?
Yes, doctor, we have recorded the presentation. I'll be sending it to you.
Okay, you have.
Also, we are going to share it to members. We are going to be sharing it to members.
Oh, okay, fine.
Yes. Otherwise, thank you very much for giving us this time and delivering this wonderful presentation.
Okay, thank you again, yeah.
Yeah, members, maybe for more clarification, Dr. Rashmi Hegde is a wife to Dr. Vivek Hegde. Dr. Vivek was here. The endodontist was here.
And he had some fond memories there, yes.
Yes, last year's UDA AGM and scientific conference.
Yes.
Yes, so Doc, I think if you have any closing remarks for us, we are done with.
I'm happy that I was invited for this platform, and we are more than willing to share our knowledge and whatever cases, anytime you want any discussions and all, we are open to that.
All right, thank you very much for the offer.
And I don't know how many periodontists are on the board here right now, but generally these procedures are done only by periodontists because it forms the core of periodontal therapy. But because of implantology now, a lot of such procedures are being done by general practitioners also, because they need to augment the sites around implant, or if there's any recession around implant. I have not gone into the aspect of implantology today, because I restricted myself to the teeth part of it. But these procedures are also being done around implants at a great level in today's time. So the scope of this is widening a lot now.
Actually, we have only 2 periodontists in the country. The whole country have only 2. Yeah.
Okay. 2
so I'll be
in the country. That's like very less.
Okay, doctor, before the end of the year, I'll be contacting you for one more presentation.
Which one, sir?
I'll be contacting you for one more presentation before the end of the year.
Okay, sir.
Hopefully, we can have a presentation on lasers. We would really appreciate that.
Yes,
lasers would be the key, because I think
we work a lot on lasers, so definitely, yeah.
Right.
Thank you very much once again, Dr.
Thank you very much, Doctor.
Professor.
Have a nice weekend.
Thank you, sir. Thank you.
All right.
Good evening. Bye.
Okay, bye. Bye. Thank you.